So I'm very excited to welcome Professor Audrin Lenin. Professor Lenin is a specialist physician and obstetric physician at the Christian Medical College and Hospital in Vellore, India. Audrin completed his undergraduate and postgrad training at CMC Vellore, and he's now an associate professor there in the Department of Internal Medicine, where he also works as part of the obstetric medicine team. He has several publications to his name, and he has a specific interest in the management of dengue in pregnancy. South Africa and India obviously have quite a number of similarities, especially when it comes to infectious diseases. And while infectious diseases is a huge burden in pregnancy here, I think it's even more so in India. So what I'll do now, I'll hand over to Audrin and hear what he has to say, and we can go from there. Over to you, Audrin.
Thank you, Jarrod. Thank you for the introduction. It's been an honor to speak to you regarding infection in pregnancy, which is a topic quite dear to my heart. Before I start, I just want to understand what is your understanding and what are the struggles which you face regarding dealing with infections in pregnancy. So if you could just open menti.com and type in the user code at the top, 69493897, or you can just scan the QR code on screen, just so that I understand what are the issues that you face and I can tailor my talk accordingly. Okay, so I see that quite a few of you see infections in pregnancy, but prescribing antimicrobials is a little scary topic for everyone. Well, just start off with how we started, and because infections in pregnancy is quite close to our heart. And this happened 10 years ago when we had a patient with dengue who passed away with pregnancy. And when we did the audit, we realized that the obstetricians were not very comfortable when there's a medical problems, and the physicians were not very comfortable when there is a pregnant patient. And we were losing quite a lot of women in that gap between the two specialties. And we started our obstetric medicine services after that. And in fact, our in hospital maternal mortality has come down by 80% after that. When we talk about infections in pregnancy, it's quite tempting to broadly classify it into obstetrical causes of fever and non-obstetrical causes of fever. But we realize it's a little bit more nuanced than that. And we now broadly divide it into 4 subcategories. One is infections which are caused because of pregnancies, such as the surgical site infections after the cesarean section, episiotomy wound infection, breast abscesses, mastitis, chorioamnitis, and a postpartum sepsis. So these are things which are related to pregnancy. There are some infections which are more common in pregnancy, but they're not related to pregnancy itself. Things like malaria, for example. In malaria, a study in Gambia found that the Anopheles mosquitoes likes biting pregnant women more than non-pregnant women. And other infections like listeria, HIV, varicella, these are all more common in pregnancy. The third set of infections is because these patients are in hospital, they have a higher chance of developing hospital-acquired infections, catheter-related thrombophlebitis, wound infections. And finally, we have the normal set of infections, which are common infections which can happen during pregnancy, irrespective of whether the patient is pregnant or not. And when we broadly look at infections in pregnancy, we are looking at 2 main things. One is whether pregnancy itself increases the susceptibility of developing this infection. Or second is if pregnancy causes the infection to be more severe. And when we look at it, there are some infections which are more susceptible in pregnancy, like listeria, malaria, and HIV. And quite a lot of infections are quite severe in pregnancy, such as influenza, hepatitis E, herpes virus infections, malaria, and varicella infection. Some of the viral infections, especially in first trimester, are associated with a lot of fetal anomalies, especially CMV, varicella, rubella, herpes viruses, hepatitis viruses, and influenza. And in fact, people have noted that every time there is a viral pandemic, the maternal mortality rate always goes up. And this we saw even during a SARS-CoV-2 pandemic, which happened a few years ago. So looking at this infections, my colleagues did a study where they looked at all infections in pregnancy. So they looked at 20,000 women over 1 year, out of which 192 of them had infections and 180 of them gave consent. And we found out that the most common cause of infection in our patients was airborne and urinary tract infections. There was a big chunk of peripartum infections as well, and another big chunk of vector-borne infections. And when we looked at the outcomes, we found that the maternal outcomes were especially poor with GNB sepsis, and fetal outcomes were poor with GNB sepsis, scrub typhus, dengue, and viral fever. So now that we understand why it is important to identify infections in pregnancy, I'd like to slowly take you through how to approach a patient who's pregnant and you're suspecting infections in them. So the initial history and examination is very, very important, even more so in a pregnant woman. In fact, for all our patients, we suspect infections. We take at least the history and examination is done at least 4 times for these patients. You need to rule out non-obstetrical causes of fever. Then you have to look for the system involvement, whether it's a respiratory system involvement, if they have urinary tract symptoms, diarrhea, looking at the various system involvements in these patients. You also have to ask travel and contact history. This is very important. For our patients, it's even more important because the local culture here at 6 months of pregnancy, the woman moves from her husband's house to the mother's house. And there's always a travel history associated with pregnancy in our patients. So it is important to take travel and contact history. Drug history, especially with the advent of neuraxial anesthesia, they have a higher incidence of fever because of that. And on examination, examining the vital signs is extremely important, along with etiological clues such as a eschar, a maculopapular, a congested throat. This we'll go through in the cases that we discuss at the end and on why all these is important. Along with these, you also need to take history regarding the obstetrical causes of fever, such as a prolonged labor, premature rupture of membranes, if they have had multiple vaginal examinations, if there is an intrauterine instrumentation or any device placed. On examination, if they have any fundal tenderness or abdominal tenderness, and if they have a foul-smelling amniotic fluid or vaginal discharge associated with that, and finally looking for fetal tachycardia. Coming to what investigations will you do and how for in pregnancy, there are 2 things you need to look at. One is what investigations are safe in pregnancy. We always get into fights with our radiologists regarding getting investigations done in pregnancy. The other is how reliable are the usual investigations that we do in pregnancy. So when we look at interpretation of investigations in pregnancy, we should understand that the WBC count in pregnancy usually goes up. During labor, it can go as high as 29,000. But if there is a leukocytosis with a left shift, with the presence of band cells, with a clinical suspicion of bacterial infection, you need to suspect bacterial infection, but don't get into a false sense of the counts are high, so there is no infection. In the liver function test, alkaline phosphatase is produced by the placenta and it will be elevated. And you also need to consider pregnancy-specific liver diseases in looking for infections. The creat normally falls by 0.4 milligram per deciliter in pregnancy, and serum creat of 1, which might be normal in a non-pregnant person, reflects renal impairment in pregnancy. Blood culture is one of the most important tests. All our pregnant patients with fever get blood culture. And in a study done in China, they found that 5% of the patients with systemic fever had systemic infection. And studies have also shown that undiagnosed bacteremia have a higher, very poor prognosis, increased chance of sepsis and shock. When you look at urine analysis, urine microscopy is preferred over just a plain dipstick because plain dipstick has a high false negative rate in pregnancy. Urine culture is the gold standard. All our patients get urine culture at least once during the pregnancy. There are some practical issues with using it as a screening test. Anyone with the clinically suspected lobar pneumonia, we do sputum gram stain and culture. And anyone with fever and cough for more than 2 weeks get evaluated for tuberculosis with a TB PCR. When our patients come with fever, with flu-like illnesses, we do PCR for SARS-CoV-2 and influenza. And if there is a membrane on the throat, we do diphtheria PCR as well. The amniotic fluid testing is usually not indicated unless you're not sure regarding the diagnosis of chorioamnionitis. It's technically the gold standard, but there are a lot of issues with practicality for it. Now, I'm sure all of you struggle with getting radiological investigations done in pregnancy. I just want to know, according to you, which are these radiological investigations which can be safely done in pregnancy? It's the same Mentimeter login and the code, menti.com 694938897. If we just vote on this, let's see what the current consensus is. So if you have a pregnant patient and you want, which are these radiological investigations which you can safely do? You can vote for more than one option. Excellent. So when we look at radiological investigations, chest X-ray is safe. So the chest X-ray, the radiation to the fetus is around 0.0005 to 0.01 milligram. And the risk to fetus is only when the radiation exceeds 50 to 200 milligram. And so chest X-ray with an abdominal shield is safe and not contraindicated. When you look at CT imaging, CT chest or a CT pulmonary angiogram is safe with a shield. Issues come when you have to do a CT pelvis or abdomen where the radiation risk is much higher. Oral contrast is safe. With IV contrast, there is a theoretical risk of the free iodide in the contrast affecting the fetal thyroid gland, but it's just a theoretical risk. When you look at MRI and imaging, the plain MRI is safe in pregnancy. There is a theoretical risk with gadolinium to the baby. In a large retrospective study, they found that there was higher incidence of neonatal deaths and stillbirths with gadolinium. But when you look at risk versus benefit, if your benefit is more than the risk, you do go ahead with MRI and GAD. Ultrasound is definitely safe in pregnancy, but remember that you can have hydrourethronephrosis because of the gravid uterus. Slowly, we are moving more into point of care ultrasound, where it is slowly becoming part of our clinical evaluation at the initial presentation itself, where especially with patients with breathlessness, we look for lung consolidation, if there are B lines, screening of the abdomen. It's become part of practice now. When you look at the biological markers, CRP has high sensitivity in pregnancy, but a very low specificity in pregnancy. ESR will be elevated because of pregnancy itself, so it's not very helpful. The ideal marker is interleukin A, but it is usually used in research setting and it's not clinically used quite a lot. Next, when you look at what antibiotics can you use, there are a few things you need to consider. This is the antibiotic choice rational. Second is it safe in pregnancy and lactation? And third is, will the dose, absorption, distribution, excretion change during pregnancy? When you look at the antibiotics in pregnancy, this is the FDA categories, which I think everyone knows, where A is adequate studies have shown that it is safe, and excess studies have shown abnormalities and there is a risk of harm, with B, C, and D in between. In 2015, FDA had tried to move to this new labeling where instead of this A, B, C, D, and X, it was more a descriptive label regarding what are the risks with it. It's not still fully enforced, but this gives us a much better idea of what the drug does compared to the old labels. When you look at antibiotics, penicillins are definitely safe. They have been studied for a long time, can be used easily. Only issue is with clavulanic acid, there is some studies which have shown increased incidence of necrotizing enterocolitis in the newborn. So usually we avoid it after 36 weeks and during the peripartum period. Cephalosporins are safe. We prefer older cephalosporins because the evidence is better with them. Macrolides are also safe. Among the macrolides, we prefer azithromycin over erythromycin because there are some case reports of erythromycin causing hepatotoxicity in the second and third trimester. Aminoglycosides are a bit of an issue because they do cause damage to the immature nephrons, and with streptomycin, there is an increased incidence of hearing loss in the baby. If you have to use aminoglycosides, gentamicin is the best choice because we have the maximum experience with it. Metronidazole have shown some teratogenic effects in animals, but these have not been shown in the humans. You try to avoid it in the first trimester, but after that, definitely you can use it. Tetracyclines are the big bone of contention where traditionally they are contraindicated in pregnancy because they cause discoloration of the teeth, bones, and cartilages. There are few recent evidences which are showing it is safe, but it is very difficult for a pharmacologist to prescribe it to any pregnant patient. Cotrimoxazole is relatively safe. There are some teratogenic effects in animals, but not in humans. We do use it up to 36 weeks. After 36 weeks, you use it with caution because it can cause kernicterus in the newborn. So we are a little careful after 36 weeks with cotrimoxazole. Quinolones initially were contraindicated, but recently in 2018, there was a large meta-analysis which showed that they are safe. If you have to use a quinolone, we would use an older one like ciprofloxacin because they are well studied. Now that we have covered the approach to infections, shall we just go through a few cases? Some are quite common, some are very rare. But we'll just go through this cases to see how do you approach a patient who's pregnant with infection. So the first patient which we had was who was pregnant for the first time, presented to us at 12 weeks. She had an underlying comorbidity of undifferentiated connective tissue disorder on a scleroderma spectrum. She was on methotrexate and HCQ. She had previous unprovoked pulmonary embolism for which she was on apixaban. 2 weeks ago, that is when she was 10 weeks pregnant, she developed varicella zoster infection. And during her routine ANC checkup, her HIV test was also positive. On examination, her vitals were stable. She had healed varicella scars, but the rest of the systemic examination was normal. So when she came to us, she had issues related to infection and pregnancy where, first of all, she had first trimester exposure to methotrexate, which is a category X drug. She had first trimester exposure to varicella infection. She had first trimester exposure to apixaban. She had HIV infection, and she had a procoagulant state. So when she came to us before that, varicella in pregnancy is, especially in first trimester, can cause congenital varicella syndrome, where there's microcephaly, neurological developmental defects. microphthalmia, cataracts, and later on they have a higher incidence of growth restriction and higher incidence of spontaneous abortion. Regarding HIV in pregnancy, early initiation of ART as soon as the infection is diagnosed to start ART is shown to be beneficial. Initially, there was some controversy regarding using integrase inhibitors, but now they are the standard of care, especially because they bring down the viral load rapidly. So especially late in pregnancy, when you want to get the viral load as low as possible, as fast as possible, integrase inhibitors are the best. Post-delivery, there are issues with starting retroviral therapy for the newborn. I'll come to our guidelines and the South Africa guidelines after this. And the traditional school of thought was vaginal birth is better than cesarean section. The new evidence shows that if you look at vaginal births and cesarean section, if you compare it with elective cesarean section versus an emergency cesarean section, for an elective cesarean section, vaginal birth and cesarean section are similar. But if it's an emergency cesarean section, the risk of infection is much higher. So in our patients, CD4 was 511, OI screen was negative, her syphilis screen was negative. We started her on tenofovir, lamivudine, and dolutegravir. We stopped the methotrexate, changed her to azathioprine. We stopped apixaban, changed to low molecular weight heparin. But unfortunately, she had a spontaneous abortion at 20 weeks. A year later, she came back to us saying she wanted to get pregnant again. This time, her baseline screening, her CD4 was 506 and the viral load was less than 150. She was continued on tenofovir, lamivudine, and dolutegravir along with azathioprine. We had restarted her low molecular weight heparin. Last updates on her, she had a twin pregnancy. She delivered both babies are healthy and the babies were given ART prophylaxis after birth. With regarding the prophylaxis, this is the Indian guidelines for post exposure prophylaxis for the baby. Especially if the mother is diagnosed with HIV during pregnancy and is well controlled, we initiate maternal ART and give nevirapine for 6 weeks postpartum. But if there is a doubt that the infant is infected, you do DNA PCR for the baby at 6 weeks or earlier, and based on that, start antiretroviral therapy for the infant. I do realize that the South African guidelines are a little different, where we give a single dose regimen. The South African guidelines use a triple drug with zidovudine, lamivudine, and nevirapine. This is the 2023 guidelines for HIV. But I do understand that our HIV load is much lower. In fact, when in 1990s, we had quite a high incidence of HIV. We had around 2% of our pregnant women had HIV. Since then, there's been a robust HIV control program which was initiated by the government. And the last few years, the trend has come down quite significantly. In 2018, we had the HIV prevalence was 0.2% per 100 pregnant women. And in fact, since 2018, it's come down even further. In the last 3 years, I've just seen one patient who was pregnant with HIV in the last 3 years. Going to the next case. This is a set of 2 cases who I'll try to contrast these 2 cases who came with similar history. So first was a lady who was 29 years old, was primigravida at 24 weeks of gestation. Had primary infertility, she conceived with IVF. She came with history of fever, cough, and breathlessness for 1 month. Cough was associated with mucoid expectoration. And for the last 2 weeks, she had difficulty in moving both her lower limbs. On examination, she was tachypneic, requiring 10 liters of oxygen. She was tachycardic. She had neck stiffness And she had a upper motor neuron weakness of both the lower limbs with 2 by 5 hours in both the lower limbs, exaggerated reflexes, upgoing pointers. And she had bilateral mild inspiratory crepitations. This is one patient. The other patient came with a similar complaint. She was at 28 years old. This was her second pregnancy, came at 16 weeks. She had traveled 1,100 kilometers to come to us. She came with history of cough for 1 month. This cough became worse whenever she lies down. For the last 1 month, she's been sleeping sitting up, uh, but she didn't have any fever. On examination, she was not in any respiratory distress. She had bronchial breath sounds in the right lower zone, and her liver was slightly enlarged and palpable, and it was tender. Look, the first patient, we did this X-ray. If you zoom into this X-ray, it's very difficult to show virtually, but you can see this miliary mottling on the X-ray for the first patient. The second patient, this was the X-ray. I just want you to look at this X-ray. We'll discuss in a little bit more detail. That's the X-ray for the second patient. Just have a look at this X-ray. The first patient we did do, in view of the lower limb weakness, neck stiffness, we did an MRI, brain and spine. There were multiple ring enhancing lesions in the brain and the spinal cord. And CSF showed 30 WBC cells with a lymphocytic predominance. Her protein was significantly elevated in the CSF. It was 2.7 grams. Her CSF PCR was positive for Mycobacterium tuberculosis, and it was rifampicin sensitive. So she was started on antitubercular therapy with dexamethasone. We started her on isoniazid, rifampicin, pyrazinamide, and ethambutol. Paraparesis improved, and she was referred to the family physician for continuation of the antitubercular therapy. When you look at TB in pregnancy, maternal TB is associated with much higher incidence of spontaneous abortion, perinatal mortality, small for gestational age baby, and low birth weight. And usually it is seen that in pregnancy, there is a much longer delay in diagnosis compared to someone who's not pregnant. This is associated with people being hesitant to evaluate for TB in this women. When you look at the anti-tubercular drugs, rifampicin is safe. Only thing is the infant would need a vitamin K supplementation at birth in view of the hypothrombinemia. Isoniazid is safe for therapy as well as for chemoprophylaxis. Pyridoxine, you need to use a little higher dose in pregnancy. Ethambutol is also safe. Pyrazinamide is little controversial, which WHO says it's safe, but CDC says it's not. But we do use pyrazinamide safely in our patients. Bedaquiline is a newer drug. Initially, there was a lot of concern regarding bedaquiline in pregnancy. It has a higher incidence of low birth weight, but it is overall safe in pregnancy. Only issue is with streptomycin, where there are issues of nephrotoxicity and ototoxicity in the fetus. Going on to the second patient, the X-ray which I showed you. This is the MRI coronal section of that patient. This is a cross section of the liver and the lung. Okay. Have a look at these images. So this is the lung, the liver. This is in the liver, and this is in the lung. Okay. So what's your diagnosis based on this images with the history? Came with history of 1 month of cough, not able to lie down flat because of the cough, and the X-ray and the MRI findings that you saw. You can use the same Menti code. Okay, excellent. So it is a hydatid cyst. So she had if you see, you can see that these are look like worms, but these are the septations, but you can see this worm here. There's a worm here as well as in the liver and the lung. So it is a hydatid cyst. So this patient is currently admitted with us, and she is planned for uh, thoracotomy and excision of the lung cyst as well as the excision of the liver cyst. She's in second trimester. This is the best time to do that. The other option is a pair, but in view of such large cyst and risk of impending rupture, we are taking her up for surgery. She'll need albendazole post-surgery. Albendazole in first trimester is contraindicated, but in second trimester, you can use albendazole. The next case, she's a lady who had come with at 30 weeks of gestation. She came with history of fever for 9 days, with cough for 3 days, breathlessness for 1 day, and she lives in a village. She works as a farmer. Every day when she washes her clothes, she puts it on. There are a lot of shrubs around her house. She puts them out to dry on the shrubs near her house. When she came, her pulse, she was tachycardic, she was tachypneic, she was requiring 6 liters of oxygen to maintain a 98% saturation. Her respiratory system showed bilateral diffuse Krebs. And on examination, we found this lesion on the undersurface of her breast. So discussing this patient to explain why history and examination is extremely important in anyone who comes with infection and pregnancy. So the history of her putting the clothes out to dry over the shrubs and this lesion over the undersurface of the breast is classical of a rickettsial infection called scrub typhus. So scrub typhus is a rickettsial illness caused by Orentia sutsugamoshi. The vector is a trombocollid mite and usually present with fever, elevated liver enzymes, thrombocytopenia, and ARDS. And the classical clinical sign is the eschar, which I showed you. The issue here is the drug of choice for treating rickettsial infections is doxycycline. And doxycycline is contraindicated in pregnancy. And it is very difficult for a pharmacist to prescribe it to us if the patient is pregnant. We usually use azithromycin for a non-severe scrub typhus patients. But if there is a severe illness requiring ICU care, we do still use doxycycline, understanding the risk of doxycycline. So our colleagues did a study where they looked at RCT comparing doxycycline, azithromycin, and both for severe scrub typhus. In this, they found that the combination therapy with doxy and azithromycin was definitely better than doxycycline alone or azithromycin alone. But what was more reassuring to us was this graph, which showed that azithromycin was not worse compared to doxycycline for scrub typhus. And so for our non-severe scrub typhus patients, we do use azithromycin instead of doxycycline. But if they have severe illness requiring ICU care, we do use a combination therapy of doxycycline and azithromycin. We looked at all the scrub typhuses in pregnancy presenting to us, and we found that it had ICU admission rates of around 70% and very high fetal loss rates of around 42%. So it is common in our area, but you do need to ask for history of travel, do a thorough clinical examination to identify rickettsial infections. The fifth patient who presented at 10 weeks of gestation, who came with history of fever for 10 days, with the highest recorded temperature of 101 degree Fahrenheit. She had headache for 2 days with severe myalgia. And she, after her pregnancy was confirmed, she moved back to her mother's house. In her mother's house, her mother has 2 cows. While she was taking care of the cows, she takes care of the cow dung in the house, cleans it, gives bath to the cows. And all this she's been doing for the last 4 weeks. And after that, she's had fever for the last 10 days. On examination, her vitals were stable and the systemic examination was normal. In view of this history of exposure to a cow, we were worried about brucella in her. So when we did a blood culture, we asked a microbiologist to look for brucella, and it grew brucella in her blood culture. She was started on cotrimazole for the brucella along with rifampicin. Currently, after this happened, we explained the issues with the cow, and she moved back to her husband's house, which does not have a cow. Her fever subsided. Repeat blood culture after 6 weeks showed clearance of the infection for her. So rifampicin is safe in pregnancy. Septran, because she was early first trimester, we could use it in her. We are a little bit more careful after 36 weeks with cotrimazole. Final case. Okay, so this is an easy one. 21-year-old came at 14 weeks of gestation, came with high-grade fever, chills, rigors for 4 days. She was vomiting profusely and she was prostrated. On examination, she was pulse was 100 BP of 90-60. Her spleen was palpable 4 centimeters below the left costal margin. Rest of the examination was normal. She came with a severe anemia with thrombocytopenia, and her malarial smear showed vivax gametocytes and schizoids. Okay, I think malaria is a common infection in pregnancy for both India and South Africa. So let's see, how do you treat this patient? So she's come with a severe malaria, and her peripheral smear showed vivax gametocytes and schizoids. Excellent. So most of you are correct. So severe malaria, irrespective of whether it's falciparum or vivax, needs IV artesunate. Our patient, once she was able to take orally, it was changed to artemether lumefantrine, and she was put on weekly chloroquine prophylaxis till delivery. So malaria is a major problem, especially in the tropics. Both India and South Africa are in areas which have a high incidence of malaria. South Africa has a much higher incidence of Plasmodium falciparum. We have a higher incidence of vivax. When we look at malaria in pregnancy, as I said initially, the malarial the Anopheles mosquito loves biting pregnant women. Along with that, they have a higher incidence of placental infection. In fact, a study in Tanzania, 46% of the patients with placental infection had no parasitemia in the blood. There is this pregnancy-associated malaria variant surface antigen, which causes the erythrocytes to go and get stuck to the syncytial trophoblast. And because of this placental infection, there is decreased uteroplacental flow. There is decreased villus growth and development, and higher incidence of fetal growth restriction and stillbirth. The diagnosis, the old things that we used to use were thick and thin smears. The parasitic specific antigens are slowly coming in. But the thing that we use in our institution is a quantitative Buffy code, where we stain it with acridin or orange and look at it under UV light, and it just lights up under the UV light. So very easy to identify it with an acridin or orange stain. PCR is the gold standard, and you are able to identify resistance with it. For an uncomplicated falciparum malaria, first trimester is artemether lumefantrine. Second, third trimester, also artemether lumefantrine is the drug of choice for us. If by chance you get a chloroquine sensitive falciparum malaria, you can treat them with chloroquine 600 mg base. For severe malaria, irrespective of what type it is, you need to treat with IV artesunate, irrespective of trimester, lactation, organism. IV quinine is an alternative agent. IV therapy should be given for at least 24 hours or until the patient can take orally. For non-falciparum malaria, which we see more often, the drug of choice is chloroquine. For other considerations regarding, especially with Vivax, the anti-relapse therapy, primaquine we usually avoid because we do not know the G6PD deficiency status of the fetus. So in pregnancy, we give chloroquine prophylaxis weekly till the completion of pregnancy. Post that, we check the G6PD levels of the newborn, and based on that, decide continuation of the chloroquine prophylaxis. Always give folic acid along with the anti-malarial drugs. And any fever in the newborn born to a malarial mother, screen for vertical transmission. Vector control insecticide treated nets not just decrease the incidence of malaria, they have also shown to decrease the risks of low birth weight and stillborn abortion. And insect repellent use, when you explain to the pregnant or lactating mother, you tell them it's safe in pregnancy and lactation. Only thing is to avoid application over the nipple area while breastfeeding. Chemoprophylaxis is relevant, especially in high incidence areas. In high incidence areas, you use intermittent preventive treatment in pregnancy, where you use sulfadoxine pyrimethamine, starting at least thrice from second trimester onwards. In low to moderate areas, you can use screening and followed by that treating. If you have malaria and HIV, daily co-triamcinolone prophylaxis is recommended. But if it's a high malaria transmission area, you use sulfadoxine pyrimethamine in every 4 weeks. If a pregnant woman wants to travel to an endemic area, you recommend chloroquine 300 mg once weekly for them. I'll finish with the story of this building in your screen. So this was built by the British Raj, and it's a building in Calcutta, and it's called Victoria Memorial. So it was built with just one goal in mind, to dwarf the Taj Mahal. So it's built with the same marble from Taj Mahal. It's built with the same geometrical shape as Taj Mahal, but it's bigger than Taj Mahal. And it was built once the, I think both South Africa and India had the British Raj ruling us. This huge building dominates the skyline in Calcutta. But this is not the building which I want you to focus on. Just across the street from this building, there's one tiny brick room. And in that brick room, in 1898, the Surgeon General Ronald Ross, he identified that malaria is spread by the bite of mosquito. And I think that's one of the most important discoveries in science in the last century. And it's made much more of a difference compared to the big giant marble edifice that you see. Okay. Thank you. This is just a picture of the Velo Fort. I do invite all of you to come and visit us if possible in Velo. These are some other pictures of sites around Velo. Thank you.